So for my final lightning strike, I decided to do it on corticosteroids, specifically cortisone shots, and how they can positively and negatively affect athletes, and if they're even a good idea in the first place. The reason I chose this topic is because a Hampton City football player was considering getting a cortisone shot and or a numbing lidocaine shot for to play in a game after a recent AC sprain. So when studying the effects of cortisone on AC sprains in collegiate football, many things need to be considered, from the type of cortisone being administered, the severity of the AC sprain, and the goals that everyone has in mind for the shot. And the risks, of course. The AC joint serves as an important link between the scapula and clavicle. An injury to the AC joint from a direct mechanism can be caused by contact with another player, the playing surface, or equipment. An AC joint sprain can also occur from an indirect mechanism, which is like the athlete falling on an elbow or an outstretched hand, and force is indirectly shoved up into the AC joint. There are 6 types of acromioclavicular separations. The first 2 would be the only ones that would be treated by cortisone shots. The others immediately require surgery. But yeah, the first 2 can be treated conservatively. Landmark guided intra-articular corticosteroid injections are common procedures done by physicians for a multitude of issues, whether it be arthritis or chronic low back pain or tendinitis or tenosynovitis and stuff like that. General practitioners can give corticosteroid shots, but most of the time, if you're working with athletes, they're going to get musculoskeletal specialists or orthopedic docs to do it. The most common indication for injection is osteoarthritis, with the knee being the most common site, but like I said, it can be done for the back and for the shoulder and for the elbow and all that. It has been found that patients treated with corticosteroids injection have faster pain relief than those who received oral injections, which makes sense because you're injecting it straight into the bloodstream, whereas the oral medication has to dissolve and all that. And when looking at the duration of that, though, it was maintained over 8 weeks in one of the studies that I found. So it's believed that short-term improvement is clinically relevant because pain reduction not only alleviates symptoms, but allows patients to move faster through stages of rehabilitation. This is what the player at Sydney was looking for, was a fast pain relief, along with the ability to go out and play that Saturday. When looking at epidemiology of the injury and condition, I looked at football in particular because I was with Hampton City football this semester, and to determine the incidence rate of AC sprains, I found a study that looked at 25 NCAA collegiate sports, and the majority of the AC sprains came from football, 50%, over 25 sports, which is insane. Most AC sprains occurred during competition, that was 66%, and competition rate, it was 8.5 times more likely that you'd suffer from an AC sprain over practice. When examining football specifically, the study found that most AC sprains were caused by player contact at 59.5% and occurred while being tackled at 26% and while tackling at 17%. And the most common positions of the players that were injured were wide receivers, running backs, and a linebacker. It was only about 4.5 or only about 5% that were recurrent AC sprains. So it wasn't a very big recurrence rate. Most of them were brand new. Background information on corticosteroids. Intra-articular steroid injections have been shown to provide significant short-term benefits, as I said earlier, but focusing on pain, range of motion, and shoulder function compared with other non-operative treatments. Intra-articular injections led to satisfactory results in treatment of adhesive capsulitis with fast pain reduction, improving range of motion, like I said. However, they're time-consuming and they carry the risk of infection, which is reported that it's rare, but it could be a severe condition if it's iatrogenetic infection. Other risks that can occur with injected corticosteroids are more temporary. They can include skin thinning at the site of the injection, a loss of color in the skin, and sometimes pain, which is called a post-injection flare. Other signs and symptoms may include like facial flushing, which is like more systemic, insomnia, and high blood sugar, again, more systemic than superficial. That's why doctors usually limit corticosteroids to about 3 or 4 a year, depending on each patient's specific situation. So when looking at AC sprains in particular, you can, and if you're going with the corticosteroid, there's 2 ways you can go about it. You can do an oral injection, an oral corticosteroid, and then an injection of corticosteroids. Studies found that the intra-articular led to fast pain relief after 4 weeks of treatment, and including range of motion in that, because the less pain you have, the more range of motion you can go through. In a present study, oral applications of corticosteroids significantly improved pain, shoulder scores, and range of motion at the first follow-up. So if you're thinking follow-up 3 to 4 weeks after, about the same time, right? In a study comparing the both, intra-articular cortisone injections versus the oral, even with the high dose of oral corticosteroids, the short-term results, especially 8 to 12 weeks follow-up, were superior in shoulder scores, range of motion, and patient satisfaction with the intra-articular injection over the oral corticosteroids. It was also found that the injection without image control applied before the beginning of the physical therapy program accelerated pain relief and recovery of function compared to oral NSAIDs and physical therapy. So with little to no literature found in regards to cortisone injections in conjunction with AC separations, overall research into the effectiveness has proven to be enlightening. Cortisone injections have the effect of decreasing pain, increasing range of motion, and the ability to progress quickly through rehabilitation programs. So if you're willing to deal with some maybe short-term side effects with the small chance of infection, then intra-articular corticosteroid seems to be the way to go if you're looking to fast-track an athlete through a rehabilitation program. And that's all.